Okay, our next speaker is Associate Professor Stephen Lambert. Stephen Lambert is a public health physician, medical epidemiologist who works jointly between Queensland Health and the National Centre for Immunisation Research and Surveillance. And Stephen's going to talk to us about state-funded nirsevimab programs, learnings from 2025-26 and focuses for 2027. Thank you, Stephen. Oh my gosh. I won't touch you.
Thanks so much, Hannah, and nice to see everyone here after the first day of the conference. Thanks to the organisers for the invitation to talk tonight. I particularly want to note that this time last year I was in an Adelaide hotel room with RAC-confirmed influenza A, and the Immunisation Coalition people were so kind in terms of following up with me and reaching out. So I particularly want to acknowledge their kindness when they are... Oh, didn't need to be. Oh, let's go. Let's try that. So as Hannah mentioned, I work in Queensland Health, and for NCIS, I'd like to add my voice to the acknowledgement to country earlier on. I'm going to talk about nirsevimab. So we started thinking about using RSV antibodies last century, where animal studies showed that high levels of existing neutralising antibody prevented pneumonia with high RSV exposure, and high doses of intravenous immunoglobulin prevented development of LRTI following infection. We also knew that in human neonates who had high maternal antibodies that they were protected against severe disease. And then in the 1990s, we had this rapid succession of development and use of antibodies. Selected children in the US received standard intravenous immunoglobulin for protection. We then had a hyperimmune RSV-specific immunoglobulin developed that was used for a couple of years in the US, and then later in the decade we had palivizumab licensed. Palivizumab was good. It was a progression from the hyperimmune immunoglobulin, but it was expensive, required monthly injections, and was really only used for high-risk infants. And then we had nirsevimab, which, as people know, is a substantially higher potency product than palivizumab. And the reason for that is that nirsevimab targets this theta site at the very top of the pre-fusion protein here. That's different to the target site for palivizumab and for clesrovimab, which is the new monoclonal antibody that's coming as well. Nirsevimab has a substantially longer half-life, so just requiring that single injection to cover the season, than palivizumab due to 3 amino acid changes in the tail of the manufactured antibody. It's produced in Chinese hamster ovary cells and highly purified to get to the end product. I'm not going to talk much about RSV because I knew Ushma would do a lead-in for me, so that's great. But we obviously have annual epidemics like other parts of the world. The season's less obvious in tropical north, and we have a peak impact in terms of thinking about monoclonal antibody use in young infants. Surveillance, it wasn't on the nationally notifiable conditions list until the middle of 2021, so we don't have a long history of knowing what the data can tell us about inter-seasonal changes, year-by-year changes, variations geographically. And the way we've understood RSV in Australia is really through intermittent research, documenting impact and severity. In the second half of 2023, Sanofi approached governments, the Commonwealth Government, jurisdictional governments, to discuss providing nirsevimab for use in Australia for the winter of 2024. And because of that, we really ended up with a patchwork of use across the country, with some jurisdictions taking it up and others not, with no Commonwealth program. For those of you who were there, this slide's from Rachel Wilkins' talk earlier in the day. I won't go into it in great detail, but we ended up with states where a universal program was used, Queensland and WA. Other states where we had a more targeted program for those at higher risk, and then in the blue jurisdictions, really not much of a program to speak of, limited doses, very highly targeted. Even though the title of the talk was 2025. I'm just going to touch briefly on that was 2024. And then what happened in 2025-26, obviously the Commonwealth funded the national program, and we had maternal Abrysvo for use, infant and early childhood nirsevimab programs in all jurisdictions. They have similar elements, but they are not the same. They target different groups and have different eligibilities. So in thinking about how to talk to you tonight about the impact of that program, I did a literature search looking at nirsevimab and Australia and came up with 53 papers. Those before 2023 were largely opinion or modelling papers about how the program might work. Similarly, in 2024, no real impact papers. And then for 2025-26, 6 papers describing impact. I'm also going to show you one preprint that Ushma's already spoken about, so that's great, a website and a couple of slides from today. The first paper is a WA study, so a lot of our data come from WA, which is fantastic, looking at the effectiveness against hospitalisation in young children in WA. The first season in 2024, 3 hospitals, a case control study with 184 cases, 100 test negative controls, and coverage in each of those groups being quite different, as you might expect. So an adjusted effectiveness of 88.2%, no measurable difference in severity. So overall, a VE against hospitalisation in the targeted age group of 88%. The next paper, again from WA, but rather than a targeted study, looking at population level impacts statewide, observed versus expected, where the expected was the 2022-2023 mean hospitalisations, the eligible cohort, 71% coverage, and the impact assessed at there being over 500 fewer hospitalisations or a 57% reduction, with no change in the older, less targeted or untargeted age group. You can see here from the figure, this is in the targeted age group. You have 2022 and 23 up here, the impact in 2024, and then in the 1 to 5-year-olds, again, 2025 up here, showing no impact of the program, just with using nirsevimab. So a population level hospitalisation VE of about 57%. So that obviously combines product effectiveness along with coverage. This is a great paper with lots of data in it from the FluCan PEDS network that Ushma's spoken about, published in Neurosurveillance. I'm just going to highlight a few things from this paper. Hospitalisation using a test negative case control design, just from Queensland and Western Australia for this year, under 6 months of age, an impact effectiveness, vaccine effectiveness of about 81%, under 12 months of age, 83%. You can see here against ICU or HDU admission under 12 months of age, 91%, but with a wider confidence interval, fewer episodes to add to power. So again, a hospitalisation VE of about 81%. You might be recognising a theme. Impact of nirsevimab on test positivity. So this is work from Queensland, and rather than looking at hospitalisations, this really looks at community-based disease using laboratory testing data. And what we found in this study was that using the weekly percentage positive of specimens collected and tested in one of the large private laboratories in the state, from January 2022, using that comparison year through to December 2024, looking at comparing that key age group under 3 months of age and comparing it with 24 to 35 months of age old children. And the key findings are that there was a relative reduction in test positivity in the period where nirsevimab was used of about 42% and an absolute reduction of 6.9%. So at a population testing level, so different from hospitalisation, these are community managed illness, we wouldn't expect the VE to be as high, VE of around 42%. This isn't a VE paper, it's a coverage paper, and I just threw it in because it's interesting. This is from the Sunshine Coast in Queensland, where coverage has always been somewhat below statewide and national averages. And for this study, they looked at using the electronic medical record for all infants from the region born in their hospitals from the start of the program. And you can see quite quickly, this is May 2024, so within the first period, can you see my mouse? No, not really. So for that first month on the slide, you can see coverage really quite high right from the beginning of the program, well maintained, and then the yellow is the introduction of a Brisvo, again without much change in overall coverage, so reaching an average over that period of 72%, so a little bit higher than reflected in the air, so if you use the appropriate method you can get better coverage estimates. This study is from the ACT, which you might recall from the map, really had a targeted program along with New South Wales. And I've just included it because it highlights a number of quite nice things. In this first table, what they show is comparing, yes, a small number of palivizumab recipients with nirsevimab recipients. And what they showed was that for a positive RSV test, quite a marked reduction in likelihood of positivity, likelihood of ED presentation, and likelihood of hospital admission for the targeted cohort. They also found that in the nirsevimab period, admissions were older, they were less likely to be under 3 months of age, they were almost half as likely to be premature, they had an 8-hour reduction in mean hospital stay, and they had less requirement for respiratory support when they were hospitalised. This is a preprint that Ushma's nicely flagged with us. It's again the Flucan PED study looking at 2025 data, hybrid program effectiveness, but also Ushma showed us the Brisvo effectiveness. This is the nirsevimab effectiveness during these weeks of 2024 compared to 2025 data. And unlike the first paper, which really just looked at WA and Queensland, this excludes WA and Queensland, where we had the nirsevimab program in 2024. And hopefully you can see from the back of the room, any immunisation, 82%, maternal vaccination, 80%, and then nirsevimab, 89.5% against RSV confirmed LRT hospital admission. So again, hospital VE, 82%. This is from Queensland Health website looking at notification data, cumulative notification data year on year, all for under 6 months of age. We start up the top, 2023, then the next line down, 2024. You can see the line where the program was introduced, and within a small number of weeks, we see a plateauing of notifications. We then step down to the blue dotted line in 2025, and this year again so far in 2026. This is a slide, thanks to Rachel Wilkins, who presented today, looking at comparing jurisdictional differences in incident rate ratios between 2023 and 2024 by program type. So we have universal, targeted, or no program. The themes are, for a universal program, the reductions were higher and targeted programs were higher than no program, and effectiveness was higher the younger you were. Oh, that's Rachel. And this slide's from Danita Hennessy from MCRI from today as well. With their fantastic statewide linked data, you can see looking at maternal effectiveness for a Brisvo, infant effectiveness for nirsevimab, comparing across a range of endpoints, lab-confirmed RSV for notifications, ED presentations, bronchiolitis, RSV admissions, and ICU admissions, substantial reductions. Again, hospital admissions using nirsevimab, 86% lower in that age group. So where does that get us? What do we know? So nirsevimab use in Australia provides us with values that are equivalent to the clinical trials that led to its licensure, other global effectiveness studies, outcomes that have been found in comprehensive or other targeted programs, and hospital versus community settings. And in some settings, including in low coverage settings, we're able to achieve reasonable coverage quite quickly. 2027 and beyond, obviously Ushma's mentioned the changes that will allow nirsevimab to be considered in the same context as immunisation for recommendations. I think it's important, given emerging evidence, we monitor for differences between maternal vaccine and antibody use. And also just from a public health perspective, Australia really should be leading the way with both public health reporting and academic reporting on this topic. We do have some great work, and WA has produced really good local work, but we should have very easily reproducible material at both the national and other levels, but restrictions around conducting appropriate studies with all the available data and data sets limits what we can do. We need to have appropriately funded evaluation of new programs. So a large program like this, which costs many millions of dollars, should have a very well-funded, very clear evaluation and monitoring program attached to it. We need to make better use of AIR and the data linkage that already exists, but there are several large obstructive barriers to using the data to understand epidemiology and impact. Thanks to Immunisation Coalition, people who provided slides, people who produced the data, and of course the immunisers, particularly midwives who at the beginning of the nirsevimab program really were very quick to produce high coverage for a new product that they really knew very little about. Thanks very much.
Thanks, Stephen. Fantastic talk. And I do love the shout out to data linkage. We do need to make data linkage easier, don't we? While people in the room are thinking of a question, I have a question online. I've just lost it. Here we go. Can parents pay for nirsevimab on a private script if the child is not in any risk category?
I don't think it's available on the private market. I've not heard of anyone purchasing nirsevimab. I don't think it's just not there.
Do we have any questions in the room? Yes, Peter.
Thanks, Steve, for an excellent summary. In Queensland, do you get a different RSV circulation in the far north, and is there any differences in your nirsevimab program there to try and account for that differences in circulation?
Yeah, we have a year-round program, Peter, and eligibility not dissimilar to other jurisdictions. We're just looking at data now to look at seasonal and out-of-season impacts of that program, but look similar across the periods. You might have seen in the Queensland figure, we do have quite strong accumulation of cases up to whenever you would start a program, and I'd be hesitant to advise anyone to not have a year-round program in that context. If we only started a seasonal program, we would have had quite a number of preventable hospitalisations, which I think is unfortunate. We really want to try and get these hospitalisations and serious infections in particular down to very low levels. We've now got the means to do that, and I'd hate to think that we would step back from the current situation.
We might just do one more quick question online. With the possibility of a 12-month-old or an 18-month-old eligible for nirsevimab, would you give all immunisations together, or would you do the nirsevimab on a separate visit? Obviously, some parents may not want to have 4 to 5 vaccines at once. So I think it's the questions around giving nirsevimab concomitantly with other vaccines.
So I guess this is provide a discussion with a parent, really. How comfortable are they in receiving everything at once? Do you want to split doses? if you're looking at a second-year child, if they're having a vaccine eligible, they're probably in a high-risk category. So you'd be very keen for them to be protected as soon as possible. So you might encourage them to have nirsevimab at that visit. If you safe to give all of the childhood vaccines with nirsevimab. So if they are happy, give them. If it needs to split, try and get nirsevimab in early.
Thanks, Stephen. In the interest of time, we might move on. Thank you, Stephen.